that? Excellent. All right, so we've touched on this topic, but I looked back, it's been several years actually, and it seemed like a good time to bring it up. This actually came up partly at my University of Akron meeting as well, around student issues and kind of everything that we're all dealing with at the moment. So with COVID and beyond. So I'm going to just walk through this, and you'll probably hear my passion about it, but I'll say up front, we added a, sorry, my computer's trying to restart. We added a lecture to the medical students, third-year medical students, several years ago. Unfortunately, they lost a medical student to a death by suicide at Neomed, and so we rapidly worked to add in a discussion. And as time has gone on, and you'll probably hear that from me today, I've gotten to a point where I practically admonish students if they ever in the future make a suicide attempt as opposed to getting help. And I'm going to say that to all of you as well. We all will spend our entire careers and perhaps even our retirements around other clinical-minded people of all sorts. And if we can't even get ourselves to go talk to somebody, then shame on us. And unfortunately, we have a high rate, whether it's physicians or other individuals do in the caring professions. And that, by the way, includes attorneys, who do have the word counselor as a title as well, because they do interact with a lot of individuals, and maybe the only interaction those individuals have, and so forth. So there's a big group here. We know that veterinarians have a higher rate, dentists have a higher rate, and so forth. So you'll hear me as I say this in this brief version today of this. And just to show you how important this topic is, not that you ever want to hear about the word COVID again, but you'll notice here, January 31st, 2020, almost now 2 years ago, the World Health Organization declared COVID a health emergency. The same day, suicide makes the headline. That's a statement. And I think especially as we've been living with the COVID situation for 2 years now. So just be aware that it really is that important, that these visits have been increasing, and you'll see this is just a drill down on that article that the CDC was reporting. And then unfortunately, there are even articles about medical student suicide attempts, right? I mean, horrible that we have to even have that discussion, but we do. And in fact, it was another discussion, of course, around students at the undergraduate level in my prior meeting today. And so I'm going to get a little bit psychiatric, because I think we need to in this particular group, about what is this about? What are we struggling with? So my belief is that anything that we don't understand, we as humans automatically judge it negatively. And so I would argue that this group, if I gave you the request to write as much as you can to answer the question, what is life? You are all the best trained to do it, and you couldn't do it. You cannot tell me what is life, amoeba, all the way up through human. You really can't fully answer the question. And so we really don't fully understand life. Therefore, we really don't understand death. So the concept of dying is a struggle, irrespective of religious beliefs, spiritual beliefs. We still don't know. You can have faith, and I hope you do, because I think that helps a lot of us as well. But you certainly still don't get it, and therefore the concept is we really struggle around the idea of death, let alone death by suicide, and that hampers us in the clinical arena as well. So for years, most of my career, I was used to saying committed suicide. And the reality is that's already a pejorative way of saying something. Or no other type of death other than murder has a phrase with the word committed. So we tried for several years, it's probably right around 2014, 2015, to change it to completed suicide. That did not go well either. Survivors of suicide, that is family members who had lost a loved one to suicide, or people who made serious suicide attempts and lived, both groups are called survivors of suicide. They were like, nobody completes a heart attack or completes cancer. They die by or they die from something. So we now are in the lingo, again, words matter, especially in mental health, of died by or death by. Suicide attempt is still appropriate. There's nothing particularly pejorative about that. Obviously, it's a horrible event, but that is not, the language doesn't need to make it worse by saying committed. The other thing is that we've worked with our suicidology colleagues now. For years, we had literally in the ivory tower, we had these individuals doing great research on the phenomenon of suicide, of death by suicide. They didn't share it with us in clinical arenas. And so that finally has happened since about 2010. Dr. David Jobs, you'll hear his name a lot. I think I'll mention him later more briefly. But they've told us that people don't want to die. And I go back to my premise. We don't even know what death is. Nobody wants to die. Nobody wants to do something they have no idea what it really means. But they do want to end pain, physical pain, spiritual pain, emotional pain. They need their pain to end. And whatever's going on, they've not either found success in the help they've sought, or they've not sought help at all because of stigma and everything else around us. So to be data evidence-based here, this is the most recent meta-analysis that I could find from 2013. 19 studies with some very smart researchers who got more than one publication out of their studies, publish or perish, as they say. But you'll see here the high risk categories, which is not the purpose of today, but just so you've seen it from an evidence-based point of view. We know that men die by suicide at a much higher rate. I will tell you, however, in Summit County, as we do our data on a monthly basis and certainly an annual basis, we are seeing more women who are now choosing handguns as their method of suicide attempt, which means they die by suicide more frequently. So that could change over time if women start to do that more regularly. This is just a quickie chart that shows you what's happened in the United States in terms of death by suicide, and it doesn't look like a good chart, does it? We've had a slight decrease from 19 to 20, although I suspect 21 is going to go back up again. So this has not been good. If you were to do the same chart for the world, it's been a downward trend. So the United States, unfortunately, is one of the leaders in death by suicide in terms of we've been on an upward slope when other countries have been on a downward slope. This is from 2015, just to give you a snapshot in time. And this is really who we're talking about today. Zero suicide in healthcare is any of these individuals who come into any healthcare setting, we should be doing something about them to try to figure out if they're thinking about suicide before they even make a plan, but certainly before they make an attempt or end up in the ER or actually die by suicide. So that's the goal of zero suicide in healthcare. You'll see here the most recent numbers, 2019, over 47,000 individuals. So compare that to 2015, it's higher. That was 44,000 something. That equates, just for those of you who like the per 100,000, that equates to 14.5 per 100,000. We did see that decrease, as I mentioned, in 2020. Lots of theories as to why, but nobody's had a good answer. And 2021, of course, the data is not there yet. It always lags actually by several months, and we just finished 2021. Here is the real crux of this, that when you look at national studies, and I'll mention Summit County in a moment, half of individuals in the month before they died by suicide had seen a primary care physician, not for suicidality. They went in for any other of the many medical issues that all of us have. And they clearly, either they were screened, given help, and it didn't work, or in many cases, they weren't screened. And so our goal with zero suicide in healthcare is to screen everybody and then have a good integrated, hence ICAN, integrated approach to getting that person help then from a mental health professional. You'll see that there was almost a third who actually had seen a mental health professional in the sample and still died by suicide. So we don't know what that means exactly. The study didn't drill down, but obviously whatever interventions were made were not helpful in those situations. I noticed a good number are in the emergency department in the 2 months before their death by suicide. In Summit County, our numbers were higher than all of these in terms of interacting with the healthcare system prior to a death by suicide in the 1 to 2 months. The ER in 2015, which was the worst year in Summit County in terms of deaths by suicide, we went from our average of 75 a year, which I took all the way back to 1983, and we actually jumped from 2014, we had 76. In 2015, we had 110. And we still don't know why that was. The whole country was higher. Nationally, we were higher, and Summit County was horrible. Fully a third of those individuals in 2015 had been in the emergency department in the 2 months prior to their deaths by suicide. So lost opportunity to catch them. And the point is that our healthcare system is not suicide safe. We have all the cheese slices arranged the same way. And as a result of that, I'll cut to the chase, people fall through the hole. And what we want to do is have this overlap of all this information we now know from our suicidology colleagues with healthcare in every setting. Whoops. So that would include even the newest ideas like accountable care organizations. We want to see this everywhere. And I'm going to show you that this has actually been done. This is not a pipe dream. It hasn't been done nationally, obviously, but this is not a pipe dream. So this is the Henry Ford Health System, very large health management organization in Michigan, not quite as big as Beaumont, which is the one that almost bought Summa, and it kind of fell through as COVID hit. But so this shows you where they were. Notice this number. This is the same scale, 110 per 100,000. Way worse than the national average, especially back in 1999 when we weren't nearly as high. They launched what they called a perfect depression care program. That was their phrase. And notice in 2009, they actually had 0 deaths by suicide. My understanding is they also had 0 in 2014, although I haven't found a grid for that. And this number, 2009 being 0, is the reason you'll notice the bottom of a lot of my slides, 2010, we have this National Action Alliance for Suicide Prevention. This was launched by the federal government, and it's taken on a life of its own. And the whole point is we need to try to get rid of death by suicide, especially for individuals who touch the healthcare system. Indeed, there are some people who never touch the healthcare system, and we're not going to prevent them through the mechanism I'm talking about today. But it's important. So we want to rearrange, as I've done here, the cheese slices so that we catch people. We want to catch them with a screener and then hand them off to an assessment. Not, I'm going to set you up with an appointment with Dr. Weiss in 6 months, right? That doesn't work, right? So, and then we'll be able to avoid that. We want to do collaborative safety plans and be able to help people control their weaponry so that they don't use it for their own demise or someone in the household doesn't accidentally use it. It's not gun control, and that's a whole other lecture. But that, of course, gets mired in politics, as too many things do in this country. We actually learned from our suicidology colleagues we can treat suicidality separate from the depression, separate from the schizophrenia, separate from the anxiety. We can actually treat suicidality itself. That's the other big takeaway that we've learned from our colleagues. And finally, and Portage Path is on here today and so forth, a lot of places in Summit County have now engaged in this last one, which we call caring contact. It actually has a very high evidence base. They have done this with email, snail mail, postcard snail mail. You can't write as much on that because of HIPAA and because the postal carrier can read it, text and phone calls. And in those scenarios, I'm not seeing smoke signals yet, but it would probably still work. In those contexts, the decrease, if you reach out to somebody 2 to 3 days after they have left an inpatient setting and moved to an outpatient setting, so going from a higher level of care to a lower level of care, or they've called a crisis hotline or they've used the crisis text line, if you reach out to them and say, I'm checking on you to see how you're doing, that's all it is, very simple, it will decrease the suicide attempt or reattempt rate by as much as 50%. And it costs almost nothing. So our agencies have pulled together and a lot of them are working on this, and some have implemented it several years ago now, where they'll send a letter. One of the agencies, and I'm forgetting which, it might be Portage Path, actually pulled together their outpatients. They did an art contest. The patients chose the best artwork. They turned them into cards, letters that you could, like a Hallmark card, and they can write a nice note on the inside, a handwritten note. How often do you see that nowadays? That says, checking on you to see how you're doing since we talked on whatever date. And they mail that to the people at their homes. And ideally, we haven't measured it yet, it is saving lives. So again, the whole point of this is to shift from, oh, it's someone else's job to deal with suicidality or pessimism, no, it doesn't work, or one-shot trainings or crisis, is to change it to, it is what we do, it's part of everyone's job in healthcare, not just psychiatry and mental health people, but everybody. That's why integrated care is a great place to talk about this. These are the 7 components. I won't belabor those today for time's sake, but you can go on their website, zerosuicide.org, There's also a zerosuicide.com. Both are ripe with information. All of it's free, and it walks you through these 7 components plus tools, which I'm going to show you now. Here's the 2 websites, so that at least you're aware of that. They also include on those websites how to do a workforce readiness survey to make sure that staff know what to do from the front door at the reception desk all the way through to the highest trained individuals treating people. Let's get concrete for a moment. This is Henry Ford. This is what they did. This is an updated version you'll see in 2011. But the bottom line is, this is the simple thing they did, is they started screening everybody. They included alcohol, which of course is a depressant. They included, this is what they changed actually from the earlier times. They added in the opiates basically, but they made it a little more broad with the illegal substances. And then of course, some questions that really get into the heart of possible suicidality, including having thoughts you'd be better off dead or hurt yourself. So they're directly asking the question. This screener, which then led to an immediate assessment in their organization, is what got them to 0. Pretty straightforward. It's not rocket science. This is the Columbia. You'll see it abbreviated the CSSRS. It's actually so well validated now and evidence-based, it's embedded in Epic. So it's actually part of the gold standard electronic health record system, and I'm sure it's in others as well. I like, this is another one that the Ask suicide screening questions. This one also has been heavily validated. Again, not a lot. This is brief, right? 4 questions, 5 questions. Does not take a lot of time to accomplish this. This one I love. This one's from Arizona. Magellan gets a lot of fanfare nationally as having a very good crisis system. The Crisis Now that you're going to hear more about around mobile crisis comes out of Arizona as well. And what they do here is they normalize. This harkens me back to Dr. Spieth talking about some of his motivational interviewing stuff, in that you're normalizing first, and then you ask the question. It is a fact that nearly everyone has at some time felt hopeless. And by the way, research says that is a fact. They're not making that up. But you say that that's true, and then you ask them, how hopeless are you now? People have had thoughts of ending their lives, also way more people than you would imagine. And then you ask the question, right? And then of course the substance use, because that also gets into that. So these are really quick seconds, 30 seconds kind of screenings. Many of you are already familiar with the patient health questionnaire, 9 questions. I won't go through it as a question and answer period, but 9 questions, again, not rocket science. They took the DSM-4, now DSM-5, same criteria, and turned them into a Likert scale. Not rocket science, but it's saving lives. And for the U.S. Preventive Services Task Force, several years ago suggested that in pediatrics offices starting at age 11 and everybody beyond that, up through and then in adult offices in internal medicine, in family medicine and so forth, that everybody should be screened. And the American Academy of Pediatrics also said, yes, we agree with that. And I've seen a lot of offices doing that, even with my own kids. When they were kids, they started getting screened, which I was just thrilled to see this happen for 2 reasons. One, of course, it may catch somebody with depression and get them help. And 2, that as those youngsters grow up, or kiddos, I guess we tend to say here, as those kiddos grow up and they become parents, they're going to question the doctor who doesn't screen their children for mental health symptoms. I grew up never being screened. Most of us here grew up never being screened. So this will be a sea change to make it the norm that healthcare is healthcare is healthcare, which I think is going to be awesome. By the way, some pediatrics offices said, I don't have time for 9 questions. So they actually use a 2-question item, which I've put here. The point is, if anything shows up on this, they get somebody assessment, right? So it's faster. Let's get them help. That also has been validated at this point and also works. Here it is, putting suicidal ideation on the treatment plan, not as part of or a subsection of depression or anxiety or something else. That's the issue. And then they actually treat the suicidality. This is the idea of a working plan with a patient. This is generally not done by the psychiatrist. It might be done by a social worker, LPCC, psychologist, because it's long-term therapy. It's not a 1-session deal either. And they work around the warning signs, And again, this is a sheet then the patient has with him or her to look at when they're in a moment of crisis. What are the coping strategies? Maybe you teach them some progressive muscular relaxation. You can teach them that in about 2 minutes, or other activity that they can use. People in social settings, obviously you don't want the local bar listed here. That's probably not a good choice. So what are the places they can get help? Who can they ask for help? That generally means in their support system. Professionals then, how do they reach those professionals? It includes the Suicide Prevention Lifeline, which, as you all probably have heard by now, as of July 16th of this year, will be 988. They're going to make that much simpler as the crisis number. So we'll have 911, 211, which is very active in many places, and we'll have 988. And then making the environment safe, which gets into trigger locks and lock boxes for guns in particular, but it also may mean knives and other things. And then look at the bottom. I like this a lot. Something worth living for. Your dog, your cat, your child, your parent, whatever, but something or more ideally listed there. And this is very straightforward, but takes time. This is not something that generally is done in 15 minutes. You want this to be a heart-to-heart discussion with the person. Okay. So finally, I mentioned treatment. So here are several of the treatments that are evidence-based. Cognitive behavioral therapy, not surprisingly, there literally is CBT for suicidology. We actually brought the Beck Institute to Akron in Summit County in recent years, and they trained a good number of people in CBT for suicidality. They also trained some in CBT for chemical dependency and some in CBT for children and adolescents. DBT, Dr. Patricia Linehan's particular therapy. I should have mentioned Dr. Beck sadly passed away, but he had a very long, productive life. People say, how old was he? They say he was so old that even his daughter, who had been a professional for years, was already retired. Right? So very long, productive people. DBT, very, very good for borderline personality disorder, and Dr. Linehan has helped actually by breaking the stigma by admitting finally that she created it for herself. So psychologist heal herself. She created DBT, but it works very well for suicidality. The collaborative assessment and management of suicidality. This is Dr. David Jobs. We've had him in town several times now, and then Ohio's brought him to the state many more times. He created this with his team of suicidologists in the ivory tower because he says he was tired of not being able to do something more directly to help prevent death by suicide. He flipped the classroom on this, which is awesome. So we've paid for a bunch of people in Summit County to do this. You can do the training online. It's at cost. It's not expensive. It's not even $200. You do it in your own time. And then if like an agency does this, and we've had some do this, we can bring Dr. Jobs or his team to town, and they will now help you implement it. Now that you've had the didactic piece, if you will, you can now actually implement it. For the lay public, we tend to look at AMSR, which is a day and a half. I sat through that training early in my time here at ADM board. Living Works, I've seen less of that around, but the most common now is question, persuade, refer, QPR like CPR. It's an hour to an hour and a half of training, depending on how you set it up and how many questions and answers you have. We've added this to our CIT police training now through Greenleaf. And Daniel Bennett does a phenomenal job, but we've got many other people now in the county trained to be trainers to do this. School systems, teachers, churches, we're out there. Even during COVID, they've managed to train, I think, over 1,000 people in this past year in this QPR. So that's another way to get. The point is, you want people to feel comfortable. So when you walk down the hallway and you see somebody, I just walked down the hallway here in public health, I see somebody I know, say, how are you doing? And instead of them saying either okay or I've got a head cold, they're also willing to say, I've been kind of down the last 2 days. Because for some reason we won't do that. And if we would do that, we'd break the stigma. And then this training for the lay public would be very helpful in how to persuade them to get help and then where to refer them to. And I always want to make sure I mention the National Suicide Prevention Lifeline again here, and of course the crisis text line. It does not actually matter what you text here. So actually in Summit County, they say to text the number 4 HOPE. I won't pretend to do Nicole's excellent way of saying out the letters, but so you text that. That only tells the crisis text line where you are. That means you probably heard about it in Summit County and they have a better sense. But the reality is these things trigger in localities. The national line actually in Summit County, for example, rings at the ADM Crisis Center at PEZ. So that's how these things play. This will be 988, as I said. I'll acknowledge Dr. Goldstein. She does a great job with the Suicide Prevention Resource Center. And Dr. Mike Hogan, who was our own Department of Mental Health administrator for years, having run the Connecticut system. Then after he left us, he ran the New York system. He officially retired, but he's one of those many people who doesn't really retire, as is very true, and I think in the mental health field actually a lot. And so he's still giving back by working on the Zero Suicide Initiative in the background as a consultant. So I therefore think this is going to go very, very well, and it's going to stay around forever. So my point today is we should all be taking this seriously. We should all, number one, always reach out for help if we need help. You know, it would be much better to spend 2 or 3 months, which by the way is the average, to get help, to get back on track with your life and your career, as opposed to dying and of course losing everything. And not to mention the horrible ripple effect, which is the phrase that gets used to so many more people than most people realize would be affected by their death by suicide. If we can figure out how to help people realize that in advance, of course, that would be a very good protective factor. So with that, I will stop and take questions.